Okay, howdy everybody. And my name is Jerry Parker. I'm the Associate Dean for Global One Health. And I want to welcome everybody to our inaugural for this year, 2019, Global Health Next Generation Seminar Series. And we've established this seminar series to engage students and faculty who have an interest in global health and Global One Health specifically, and in the fight against emerging infectious diseases and neglected tropical diseases. And our goal really is just to provide exposure to the topic and exposure to interest and try to stimulate and promote interest in the control of emerging and re-emerging infectious diseases, and hopefully provide some ideas to think about for our students about career pathways and what you may want to do when you grow up. I'm still trying to figure that out myself. So we're really lucky today to have Dr. Marshall Ndeffo, who's an assistant professor of epidemiology in the Veterinary Integrative Biosciences Department here in the College of Veterinary Medicine and Biomedical Sciences. His research uses interdisciplinary modeling approaches for infectious diseases to inform public health interventions and policy. His work has involved a wide range of diseases, including Ebola, Zika, yellow fever, tuberculosis, HIV, and malaria, all the big ones. He teaches graduate level courses in infectious diseases modeling here at the college. And I just want to, maybe provide another personal kind of insight. I got an opportunity 5, 6, 7 years ago to work on the National Strategy for Biosurveillance. And biosurveillance is informed by mathematical modeling in a major way. And we used to use the vision that we needed surveillance and biosurveillance, specifically like we wake up every day and watch the weather and weather forecasts, so we know what's coming and we can take appropriate actions. We're far from having that capability that we can wake up every morning and watch the forecasts for emerging and re-emerging infectious diseases. But that's the vision. That's the vision that we need to try to achieve. And we need nationally a lot more resources to try to achieve that effort. But the work that Dr. Ndeffo is doing is part of the foundational effort that one day will help us achieve that vision. So Dr. Ndeffo.
Thank you. Let's see how it goes. Hopefully.
You might have to put this a little bit closer.
Okay, is that good? Okay, thank you, Dr. Parker. Thank you for coming out. I hope this topic will be interesting to many of you. I hope that that's the reason why you're here. I would like to talk about the use of mathematical model, but here more in the sense of informing control rather than making prediction about the next outbreaks, but really how do we tackle an existing outbreak situation that we are that is unfolding before our eyes. Maybe before I start, I'll just give a brief definition of my understanding of what mathematical modeling is, and if you don't get anything out of this, maybe just get that definition and run with it. Mathematical modeling for infectious disease is simply the use of mathematical formula and equations to try to capture the main processes that control the spread of disease, but while ignoring unnecessary details. And that is really driven by three things. First, it is the biological understanding that we have of the system at hand. Secondly, is the main question of interest. And thirdly, the data. Okay? For this presentation, I really want to focus on two specific diseases, one of them being Ebola, that will be illustrating emerging disease, and the other one will be sleeping sickness, emerging, and here illustrating neglected tropical diseases. And this is part of the work that I've done in my previous institution and with collaborators in WHO and also the Liberian Ministry of Health. For those of you who do not know, Ebola virus is a zoonotic virus, and bats are considered as being the main animal reservoir, though the spectrum of species that are involved in the spread, or at least in the persistence of Ebola virus within the animal kingdom is not known. Oh, thank you very much. Humans get infected by the virus through what we call spillover events. And these spillover events happened when an individual gets in contact with an infected animal. And generally that happens either during hunting or when they are preparing bushmeat. And that is generally when an individual will get infected by the virus. And through very minimal adaptation, the virus will become, if I say that, potent to be transmitted from humans to humans. And then you will have a human-to-human transmission that may occur. And here the disease is really transmitted through the bodily fluid of infected individuals. And that may happen either when they are taking, during burial ceremony, for example, maybe they start at the bottom, when they're taking care of sick individuals, for example, at home, or in a clinic if the healthcare worker is not properly protected. And one of the big ones is really during traditional burial practices. The 2014-2016 Ebola outbreaks in West Africa was really the worst outbreak that we have experienced, at least on records. And it started in December 2013 in a remote village in Guinea. And it is believed that the children were playing next to a tree where bat stays. And after killing some of the bat, they went home and they cooked them to eat. And that is where the virus kind of got into the population. And from that remote village, the virus spread to 10 different countries. And it resulted in more than 28,000 cases and more than 11,000 deaths. And to put that a bit in perspective, the number of deaths for that single outbreak was almost 10 times the combined number of deaths that was recorded for the previous 24 outbreaks. This is just a geographical map showing the cases of Ebola in West Africa. As you can see, we say that the disease really started in Guinea, but the bulk of cases was really carried out by Sierra Leone, whereas the bulk of death was really in Liberia. Here I would like to give you some of the questions that arise as the epidemic started to unfold. These questions are definitely not exhaustive. I mean, I cannot here pretend to give you an exhaustive list of all the questions that stakeholders and public health practitioners were asking themselves at the time. But these are just some of the very important questions, especially for what I would like to present today. At the beginning of the outbreak, or even I say 6 months within the outbreak, here we are around June 2014, it was already clear that this outbreak was worse than any of the outbreaks that we've experienced in the past. And at the time, the main question was really, when will this outbreak end? Because the mindset was still, if I can say that, the DRC mindset, because a lot of previous outbreaks have happened in DRC. And you have an outbreak happening in a village, and you have cases, maybe 100 cases, but after that, generally the disease will die out. And we still kind of have the hope at the time that this disease will die out, though it was the worst that we experienced so far. Few months after that, it became quite apparent that we were dealing with something, with a different animal here. The outbreak really affected multiple countries at the time. And it was really more about now, what can we do to control this outbreak, to get it under control so that it doesn't spread any further. But few months after that, it was almost the apocalyptic scenarios. Everybody was just scratching his head, what is really going on? And it was clear that the epidemic was out of control. And now the main question was really, what must we do to get this epidemic under control? And that is really at that point in time that a lot of international aid started to come in, though at the local level, there was already a lot of local effort being undertaken. And then we started to observe that decline in number of cases. And at that time, it was really quite problematic because people were not really sure what was happening. Was it true that the epidemic was stopped subsiding, or was it something else? Was the data really a true representation of reality? And there were a lot of debate within the community at the time. A lot of people just believing that, no, that's not what's happening. We are just looking at the tip of the iceberg. That should be a lot of other cases that are hidden in remote villages, and it's simply because surveillance is not good enough that we don't see those cases. And few months after that, it became very clear that the epidemic was declining. But then we needed to figure out what type of intervention was working so that we can focus our attention on that and be able to make sure that we can stamp out that outbreak. Here, I just want to draw it back to two specific questions. The first one being, when will the epidemic end? And the second one being, what can we do to get the epidemic under control? And working with the Liberian Ministry of Health, we're mainly interested in these specific questions. We've had the opportunity to get in contact with people at the Liberian Ministry of Health, and they were very responsive, though they were very stretched thin with all the problems that they were facing on the ground. But they understood that with modeling, it would be possible to bring some insight to the intervention that they were implementing on the ground. We then worked together with them, with some of the epidemiologists in Liberia, to develop a model for Montserrado County, which is the main county in Liberia where the capital is found. And what we knew at the time is that the disease was transmitted by 3 specific routes. We had what we call the community-based transmission. Here is disease spread within the community simply by people caring for the sick, or sick people just going around because they are not so sick just to stay in bed and still thinking that they have maybe malaria or something like that. The second one was the hospital-based transmission. At the time, hospital-based transmission was very much ongoing because people were not sure what was really going on, and a lot of sick people were still going to hospital, and sometimes they were just treated as if they had a simple fever. And in that case, the protocol for Ebola prevention wasn't in place in a lot of hospitals. And the third one is the funeral pathway. Disease being transmitted during funeral practices. We then developed a model that, and this is just a very simple schematic of the model for illustration purpose, taking into account the different, called here, health stage of the disease. Susceptible individual meaning healthy, not infected yet. Those who are infected but not yet showing symptoms. Those who become infectious as they start showing symptoms. And then we have the possibility of recovering from the disease because it's not 100% fatal. Some people which simply recover without treatment, though the mortality rate is very high. Those who will die from the disease, and then we'll have the funeral practices also that contribute to disease transmission. Then, as I say here, the model accounting for transmission by caring for family members of neighbor, attending funerals, present here, and also hospital transmission. And then the hospital transmission here was incorporated into our model by accounting for, if you can say that, the rate at which people will visit hospital for non-Ebola related reasons. And here, Ebola patients just going to hospitals. And also by accounting for healthcare workers, because the healthcare workers really were carrying the highest burden for the disease during the early stage because they didn't know what is happening and they were just treating people as if they had fever or malaria or something else, and a lot of them were really dying. And we also incorporated to our model some of the interventions that were taken into account at the time, or at least considered. The first one is what we call here a reduction of community transmission. And that was done in a very ingenious way. What the Liberian decided to do, they decided to build what they call washing station at the entrance of every public building. And basically, before you get into public building, you have some kind of water station with chlorine in the water and some of the things that they had, and people had to wash their hands, and so even people had to clean the bottom of their shoes before getting inside the building. And they also had some other change within the culture that they had to make that wasn't really easy. It is a very warm society, meaning that when people meet each other, even if they don't know each other, they will have a handshake, they will hug each other, and things like that, which was very much conducive for transmitting Ebola. Then they have to start just greeting people from afar, becoming very much British. I hope there's no British person here. That's fine. Becoming very British, and and something that was very interesting. Also, some of them were just greeting with elbows. But that's what they were doing, and it's working anyway. We'll see about that. The second one was really at the healthcare level work, at the health clinic level, meaning trying to reduce transmission to healthcare workers by changing the protocol for treating people who have symptoms, Ebola-like symptoms, even before tests are being done, but also trying to provide some form of hazard suit to protect them. The third one that was a bit more controversial, but that has been very much effective in the past, even in DRC, was really what we call safe and dignified burials. And that is very hard in West Africa setting because there are a lot of very strong traditions where people have believed that if they don't clean the body of the dead will have problem in the afterlife, and they have to do that. And it was very, very problematic and quite a fight to get them to change that, or at least to allow for foreigners, if I can say that, to come. And here, foreigner doesn't just mean people from other countries, simply mean people not from the family, because the people who clean the dead are people from the family. If you're not from the family, you don't, because you will interfere with some of things. Anyway, I don't understand that very well, but that is how it goes. And the third one was case detection and isolation. Then we incorporated this last component to the model that we're taking into account the Ebola isolation unit, which are very much different from hospitals. I know that a lot of you have seen pictures of these very precarious places where you keep Ebola patients, or at least where Ebola patients were kept during the West African outbreak. And these are these treatment centers. Okay. After we developed our model, the next step is really to calibrate your model against empirical data. Because it's not just enough to develop a model. Your model has to be able to capture some sense of reality, to give you confidence that this model is not just a set of equations that are good for mathematicians or engineers, but that they are really capturing the process that you're observing. And what we did here, we consider 4 different sets of data. The first one was cases among what we call here non-healthcare workers, simply mean at the general population. We consider a case among the healthcare workers. We consider cumulative death, but also hospital admission. And the dots here simply represent the data point that we have. The red dots are the data against which the model was trained. For those of you who understand a bit how a model works, even from a statistical perspective, when you develop your model, you generally train your model against a certain set of data, before being able to make any kind of projection or forecast with that. Then the red data here are the set of data points against which the model was trained, and the blue are the data set that were used for comparison, okay? The gray shape, or whatever you want to call them here, simply represent the different scenarios that we consider into our model. Because when you deal with model, it's always important to consider the different type of uncertainty that arise. This uncertainty may be epidemiological uncertainty, maybe a kind of uncertainty coming from any type of constraint due to the system that you are dealing with, or even uncertainty simply coming from what we don't know about the biology of the system that you are dealing with. Then, as you can see here, we're quite confident in that, the fact that the blue data that were not used for model training, but simply used for model validation, gave us confidence that at least on this short term, the model seems to have a good representation of what is really going on. Okay. one of the most, I will not say one of the most, but let me call it that way, but one of the very important contribution of mathematical modeling to epidemiology is really the concept of what we call the basic reproductive number. Some people will call it basic reproductive ratio, or they have different terminology, but they simply mean the same thing. In other words, that is the average number of individuals that are directly infected by one infectious case over the duration of its infectious period, if that infectious case is found in a totally susceptible population. And that is very important because that single metric can tell us if a disease, if the introduction of a pathogen in a population will result in an outbreak or not. And that also can be used to determine how likely an intervention is to eradicate the disease or eliminate the disease within a specific population. And that is what is so important. What we did here using our model was to compute the basic reproductive ratio, basic reproductive number, for Ebola in that specific county, in Montserrado County. We did something a bit interesting here by considering the tree transmission route and trying to understand how R0 would change if one of these routes was somewhat magically eliminated from the system, okay? And you see here, but I call here total, meaning that this is just the basic reproductive number itself. But now we try to understand what happened if you're able to eliminate hospital transmission, either by just closing the hospitals or making sure that transmission doesn't happen in the hospital. We realize that R0 will decrease, coming maybe around 1.5 or something like that. If we're able to eliminate community transmission in that specific setting, again, but keeping everything else, we realize that it has quite a substantial impact. If we're able to eliminate both hospital and community transmission, that's very good. But we realize that if we're able to get rid of funeral transmission by themselves and nothing else, R0 became suddenly less than 1. It's telling us that at this specific point in time, this specific community, funeral was what was driving everything. The Liberian and the people in the Liberian Ministry of Health were very much interested also in looking at different combination of intervention. And here was just for the sake of publication that we only focus on these very highly efficacious interventions. By the way, this is a paper that was published in Science. As you can see, for example, here at the top, we kind of look for intervention for reducing transmission. What we assume is that, okay, if we're able to reduce 80% of transmission in hospital, and then in community being able to reduce transmission by this percentage, what will happen to the probability of having less than 1 case per day? And this is what will happen during the next month, the next 3 months, or the next 6 months. We realize that this intervention will basically do nothing in terms of bringing that probability to less than 1 case per day. We consider different another intervention here where we only focus on the safe and dignified burial, but only in the hospitals. Again, we realize that this also will not work. We look at isolation, the same thing. But as we started to have bringing safe and dignified burial within the community, we realized that within 6 months, we really started to see that there was really a probability, a good probability of bringing the number of cases to less than 1, at least per day. Okay. But some of these interventions can be quite difficult to be implemented because, as you can see there, we kind of require very, very high percentage, which may be quite difficult in a research constrained settings. And what we started to think about was the possibility of some form of synergistic interaction between interventions. And that is something that's very important with infectious disease, and modeling is able to capture that in a way that no other field that deal with infectious disease can. Because modeling has this ability of capturing the indirect effects that happen with infectious diseases. And we kind of thought to ourselves, because at the time that was a bit discouraging for us, and it was really even discouraging for people in Liberia. But we suddenly started to think about the possibility of the synergistic effect and evaluated a number of interventions on which I kind of illustrated here. The first one there being able to do hygienic burial, for example, hospital 100%, as you can see. But what I really want to focus on is if we're able to combine all these strategies, but even just at a 60% efficacy. And what we realized that, which is here, that purplish, is that this was the most efficacious of all these interventions. That it was not really about doing one thing very well, but if we could do everything, even just an average level, that would be very good. And that was kind of the message that we have. I really want to keep in perspective that this message was as of September 2014. Reality kind of changed afterwards. But anyway, and the part was important really to prioritize a safe burial, but that remains kind of true throughout the outbreaks. And contact tracing, because that is how you're able to go out and identify people. But also we realized that less efficacious interventions can provide can really be able to control the disease if they are implemented together. And that was very counterintuitive, I have to say that. Okay, let me try to go a bit faster here. We're also interested in trying to understand, in a setting with limited resources, if we have to go for targeted intervention, how can we implement that? If we are not able to isolate everybody because we don't have enough beds, how do we do it? Who should we prioritize? Knowing that our intention here is really to curtail the outbreak as fast as possible. Okay. We develop here an agent-based stochastic model. Don't worry about what stochastic means. It simply means probability that change over time. We mathematicians also like to use fancy words so that people think that we are very clever, but don't believe that. The model really here just account for that is the exposed period where the individual is exposed to virus, but not yet, we don't yet know if it becomes infected or not. Incubation period, but also the symptomatic, which is the infectious period. At the exception of HIV at the time, a lot of models generally look at this period as being an homogeneous thing, meaning that over that period, an individual will have a fixed probability or a fixed infectious risk. But that is not generally true. This is most of the time a continuum, which for a viral disease as Ebola is, which generally will depend on the viral load of the individual and of his contact behavior. And we were really the first to kind of incorporate that into Ebola modeling. And here we develop what we call here an infectious function for an infectious individual that takes into account disease progression, accounting for, as I say, the viral load component of the individual, but also the contact pattern of that individual. And this is simply the infectiousness of an individual I, giving here a specific state S that I'm going to talk about a bit later. Okay. We went and we started digging some of the historical data on the viral load of Ebola patients. And what we realized by just digging on this data is that non-survivors, meaning that people who ultimately die from the disease, generally have a substantially higher viral load than people that will survive. And this viral load the difference start to be very pronounced from the second day of symptom onset. And this viral load also increased very dramatically with disease progression. And again, that's specifically for non-survivors. Okay. We use a number of empirical data here to parameterize our model. We use data on the patient viral load over time. We also use data on the relative risk of infections for contact of Ebola patients, and that's considering the early and the late phase of infection, which was very important also here. We also use data on the contact pattern of patients, here accounting for not only the late and early phase of infection, but also accounting for different type of contact. Here, for example, different type of contact like sharing bed, meaning that sleeping with the same bed as someone, either because the person is sick and somebody has to care for him, or sleeping in the same room, sharing a meal with an Ebola patient. I mean, someone is infected with Ebola, not necessarily because you know, but because you're a family member, or what we call here sharing conversation. Okay, we go back into our model and we help that to parameterize a function. But what we do now is that we develop this probability. And here it is the probability that an individual I will infect an individual J. And as you can see here, this is a function of the infectiousness of individual I over time. And that is simply divided by the sum of the infectiousness of all other individuals that are infected at that point in time, and that this individual J may have been in contact with. Okay? In other words, telling us that we, if here we have no exposed individual at a given point in time, and we have an infected individual, we can kind of create some form of infection tree of who infected who. Okay? And we did that because we had we have contact tracing data that were provided to us by the Liberian Ministry of Health. And this is more kind of looking backward, it's not looking forward. But that was very important, and you will understand why. Okay, we come back again here, and basically what we do now is that having these cases over time, we can recreate what we call here all the possibilities of how this infection happens. Generally, to be able to do that in a practical way, you have to do an effective contact tracing where you trace off every single individual. But if you're in a situation like this where you have limited resources and then you just have all these cases, how do you try to figure out what your infection tree was, and if you can try to make any kind of inference from that? Okay. Then, oops. Oh, wait. Then having done that now, what we're able to do, we're able to estimate the basic reproductive ratio of survivors versus non-survivors, okay? And what we realized that is that non-survivors on average will infect 2.36 individuals during the infectious period. Compared to survivors, we seem to infect very few, less than one individual. That is on average, okay? And we look at how that number of infectious individuals can change, secondary infectious cases can change over time. And again, we still observe that non-survivors throughout the infectious period contribute more to new cases than survivors. That basically tells us that if you are able to target non-survivors in a certain way, if you had a crystal ball where you can look at this and say, you will be a non-survivor, then I may be able to curtail the outbreak, but do we really need a crystal ball? Maybe not, actually. Another intervention that we looked at was what will happen in practice if I'm able to do case isolation, have limited bed, and I just focus on non-survivors. But one thing that I know about non-survivors from a clinical perspective is that non-survivors have more severe symptoms than survivors. Because previous studies have shown that people who have highly severe symptoms, there's definitely some of an index of scoring that people who have high severe symptoms will ultimately die. The probability of dying is very high. Then basically by going by symptoms, we can be able to create a way where we give priority to specific type of patient, for isolation at least. And what we see here is that if following the 4th day of symptom onset, we're able to isolate 75% of non-survivors, we will bring a probability of eliminating the disease to up to 75%. But at the same time, if we're able to go to the community and encourage them to change the behavior, meaning that reducing the number of contacts, we observe that if 75% of individuals, if reduction of contact, yes. If all individuals, reduced, 75% of individuals, reduce at least 60% of their contact, that also will give us a 75% probability of getting rid of the disease. In other words, what that tells us is that if we have limited resources and we are able to target severely ill patients, And coupled with that, we encourage behavior change within the community, we will be able to contain the disease. And something that is very important here is that at the same time that we're doing this analysis, a Liberian collaborator decided to do something very different, because at the beginning, what they were doing a top-down approach, meaning that the government was just going out there and telling people, okay, this is what you're going to do, and they're bringing the military in and making curfews, and that was just making the situation worse. Because Liberia have a very long history of civil war, and that when they saw the military on the street, the civil war mentality came back, people became very distrustful of government. And I'm sure that even if you don't have a history of civil war, if you bring the military here in the US, everywhere in the street, I think people start wondering, what's happening, what's being cooked? Anyway, but then they decided to change, and they went to the community and started to interact with people and bringing community leaders to become public health advocates. And also they decided just intuitively that what we're going to do, we're just going to give priority to people who are severely sick. And they'd have, at the time we didn't have this result, we're still working on that. And it is well documented that Liberia was more successful than the other countries, simply because Liberia was able to do these two things. They were able not only to bring this community approach of behavior change very early on, but also being able to bring this type of approach in their selections. And Liberia was the only country that was able to curtail the spread of the epidemic even before international aid came in. Okay, I have to speed up, Mr. Ndeffo. And another question that was really on the back of my mind when we're working on that was really, what about the indirect impact of Ebola on the community? Because something that was really happening was that people became very distrustful of hospitals, because hospital became the death trap. Someone was leaving home with malaria and going to the hospital, and a few days after he was dead. And people would say, okay, don't go to the hospital, don't talk to those doctors, don't talk to those Médecins Sans Frontières people, we don't know what they're doing to our people. And they've got a lot of riot because of that. But also the health system kind of just broke down and collapsed. And as a result of that, a highly endemic disease such as malaria, HIV, and TB, the big three, the treatment coverage for this disease started to decrease significantly. And what was really my concern was, is it possible that the indirect burden of Ebola outbreak might be worse than the direct burden? And at the time, I had a student from the University of Toronto, she's doing an MPH, and she came to our university to do a practicum with me. And I got her to develop a model, though I really had to almost have all the step of the way, but she was very bright, and she is a very bright student. But the time was very short, it was very time constrained, and you couldn't really expect a MPH student to be able to do everything within such a very short time constraint. And what we're doing here was really kind of trying to compute the indirect burden of Ebola in these three most affected countries. As you can see here, the blue stand for the combined depth of these three, and all different colors standing for malaria, TB, and HIV, and the purple is just Ebola death. And it was estimated that on average, Ebola resulted in a 50% decrease in treatment coverage for these diseases. And as you can see, at 50% reduction in treatment coverage for most of these, for at least a number of these countries, especially Guinea, deaths from these other diseases were higher than the direct death from Ebola. And that was even worse for combining the three countries together. And this paper that got a lot of coverage, especially from the CDC, and they wrote an editorial on that, and they were very, very excited about that. And we also were excited about our work. We're always excited about what we do. Okay, now let's talk about, water bottle gate. For those who remember Mike Rubio. Anyway, just a bit of politics, that's fine. We, as part of the NTD Modeling Consortium, funded by the Gates Foundation, I always kind of try to acknowledge fund here. And the previous one was really funded by NSA, by NIH. And I just say that we're very, and that is a big problem. And I think that Dr. Parker mentioned that it is one of the challenges that we have, especially with emerging disease, especially when kind of situation like that happen, is that it's sometimes difficult for researchers to drift away from what they're doing to work on that, because your research is dictated by your funding. But we're very lucky with Ebola outbreak, not only because NSF put some rapid grant that we're able to get one, but also we had funding from a private donor, philanthrope, that was giving money to our research center. And that really helped us to be flexible. Then having this type of flexible funding is always very important to be able to do this type of work and to be able to contribute to this in an interactive way and having an impact on this type of situation. But this is a bit different anyway. That's just a side comment. Here we're working with the WHO, and we're really much interested, or WHO is really much interested in evaluating the feasibility of some of the goals that they have for the elimination of 9 neglected tropical diseases. And we've worked on a number of them, but here I just want to focus on the sleeping sickness. Okay. Maybe very quickly, for those of you who don't know, sleeping sickness is a vector-borne disease. It's just kind of schematic representation of what how the disease transmits. You have the tsetse fly here who transmit the parasites, and also you have a animal reservoir, especially for the Rhodesiense type of the disease. For the Gambiense, it's still a question if there's really a reservoir or not. Animal reservoir or not, though there's quite some debate in the community about that. There are 3 types of interventions to control sleeping sickness. The first one being a vector control, simply means that using a specific trap to trap the flies and to kill them. We have a passive detection where people just go to the hospital and then get diagnosed and treated, and active screening where you send a mobile team RSTs to at-risk community to screen individuals and to provide them with treatment. The WHO goal for the elimination of human African trypanosomiasis, they have 2 specific goals: the 2020 elimination goal, which is tomorrow, I hope, yeah. Basically to reducing the number of reported cases in 90% of the foci to less than 1 case per 10,000 population, as well as reducing the number of reported cases globally to less than 2,000 a year. And the second one, which is a 2030 goals, really aim to interrupt transmission completely. The WHO really wanted us to focus on the former Equator province of Liberia, which has been one of the hotspots for many years. And they provided us with data that have been collected by the WHO and the DRC Ministry of Health from the year 2000 to 2012, and it's just kind of schematic representation of what the data are. We had case screen, the number of cases, and also have cases that were detected as far as through active and passive detection, and these data were available at the health zone level, which is the kind of the unit of decision making. From the modeling perspective, the question of interest were first really trying to figure out if the ongoing intervention, if continued ongoing interventions will be able to eliminate the disease by 2020. The second one was to evaluate the likelihood of achieving the 2030 interventions, and also figuring out if there are specific health zones where we might need additional interventions. Okay. This is one of the models that we developed for the purpose. And again, just to go kind of briefly, I'm going to spare you the detail of the model here, but just want to kind of point out these 3 factors. We accounted for high and low risk group individuals, which may be very important here, because depending on the type of activities of people, they have different exposures to the tsetse flies. We also take into account the fact that it's not everybody that will participate to active screening, and that is not necessarily because they don't want to. Sometimes it's simply because their schedule doesn't allow them. They may be type of seasonal workers and they won't be there when the screening team comes, or it may simply be because they are fishermen that have to be in the sea or the river, whatever it is, throughout the day. I mean, depending on the activity, they might not be there. Then 100% active screening rate definitely may not be possible. And also the contribution, the role of underreporting here, which is very important. We fitted our models to data from each of the health zones, and we definitely, again, here having uncertainty in the model fitting, arising, again, as I say, because of some unknown that we have about the system. We also here observed some form of discrepancy a bit between the model and the data, but that was really due to the spatial and temporal resolution. But after discussion with WHO, they were fine for us to go ahead with that simply because the long trend behavior was acceptable. Okay. Here we evaluate the probability of achieving what we call public health problem elimination. That is a 2020 goal. And just for the sake of illustration here, we assume that from 2012 going forward, either passive, active and passive screening were done at the average rate of what was done from 2000 to 2012, or it was done at the maximum rate, and yes, just to capture the different possibility for ongoing interventions. We assume that, which is the baseline, there's no vector control because there's none, and also the possibility of having vector control. And what we observe from the analysis, which was also one of the questions that WHO was trying to figure out, is that the drop in the number of cases that we have been observing in the Equator province over the time, is that just an artifact of underreporting, or is it something else? And through modeling, we were able to show that no, that was more likely not an artifact of underreporting, but that it is more likely what is happening because of how active screening has been efficacious in that specific province. And we observe here that between 2 and 5 health zones were unlikely to meet the 2020 goal if vector control wasn't implemented or if active screening wasn't scaled up. But as soon as we added vector control, we realized that with the presence of vector control, we were likely to eliminate, at least achieve the 2020 goal in all of those health zones. We also consider the 2030 goal, which is what we call full elimination or interruption of transmission, zero transmission, as the WHO call it. And the same thing here, we consider means cover screening and max screening based on historical data. And again, no vector control and a moderately efficacious vector control and highly efficacious vector control. And what we observe is that between 11 and 30 health zones were unlikely to meet the 2030 goal on their current screening strategies. But however, if vector control was brought in, that changed the game. Even if we just use a moderately efficacious vector control, might be able to achieve a 2030 goal in these provinces. But also we observe that it is possible that transmission has already been interrupted in some of the health zones, because the health zones that have stopped reporting cases for quite a number of time, despite the fact that they send teams there to be able to make sure that they're not missing anything. The modeling was able somewhat to confirm that your suspicions in fact might be right. Okay. What is the take-home message here from this presentation? What I would like you to take with you is that modeling can really play a pivotal role with emerging and neglected tropical disease. And that may be fourfold. First, in understanding the dynamics of these emerging diseases, and also the dynamic of established disease, what I call established, meaning neglected tropical disease or any other type of infectious diseases. The second point is that modeling can be used here to evaluate the effectiveness of public health intervention, as we have seen. The third point here is the importance of modeling for identifying optimal control strategy for achieving a specific or desired health objective. And the third one is really being able to make forecasting about the outcome of infectious disease control. But again, as I say here, all of these are really geared towards the disease control aspect. But definitely modeling can be used for other aspects as well. Okay. Thank you. Yes. Sorry, let me. Yes. That's a good question. Well, is it a good question because we've just submitted a paper to PNS. We hope that hopefully it's going to be accepted, talking about the current Ebola outbreak in DRC. And the current Ebola outbreak in DRC is very peculiar because it's really happening in a conflict area. And that has been very challenging, but one of the ways we're able to do that here is really working with collaborators at Médecins Sans Frontières, really getting a sense of how specific conflict events have impacted interventions. Surely you may be aware of that there, for example, there's area where people, some people have specific animosity towards healthcare workers for whatever reason. And they just burned Ebola treatment center, and there are doctors that have been killed and things like that. And the way you kind of do that is that you can incorporate that as some form of change on your intervention function within your model. And that depends again on the scale of your model. If you're using, for example, what we call an agent-based model, where you're able, for example, to capture behavior on an individual level over several scales, you can really model it in such a way that in a more realistic way, if I may call it that way. For example, you can model it as, okay, an attack happened this specific day, and as a result, this Ebola treatment unit was closed for a week. Or as a result, the number of healthcare workers that went out to the community for screening was reduced by 50%, or things like that. But you may also do that in a more indirect way, but there, what you do is that you use some form of functional form. Again, forget the big word, doesn't mean much. And what you do is that it is try to capture some reduction that you have in the effectiveness of your intervention. Then there's definitely a number of ways you can do that, and that is a bit how we address that in that paper, and hopefully that paper will be out soon. Any other questions? Yes. It kind of depends on the disease. Maybe again talking about my work, we're working on the paper, but that is not about Ebola, it's about flu. And what we're doing really is a question that the CDC has been interested about for quite a number of, for a while now. Is really about treatment of high-risk patients, meaning that people are immunocompromised, as you said, or have some of underlying condition that put them at high risk of severe complication if they get flu. But what is happening, unfortunately, is that despite the recommendation from the CDC that these people should be treated within the first 2 days of symptom onset, a lot of clinicians do not do that. Sometimes they still have to test you, and which creates some delay, though the CDC recommend that don't test them. If you just have the symptom, just prescribe them the medicine. And that creates a lot of delay, and then people receive medication 7 days after, which is like useless. I mean, you just drink water. That is useless, basically. And what we're really trying to do in that model, which I've done with a collaborator and a visiting student that was just visiting me during the summer, is really looking at what will happen if the doctors start to change the practice and follow the CDC recommendation. And we are looking at what would be the benefit in 4 specific states: Texas, California, Connecticut, and Virginia. And what we have now in our preliminary result is that even if we do not increase the number of prescriptions that we have, if we just manage very well the number of people that get treated, we have a substantial increase in the number of not only cases, because that is something that people don't really think about when they think about treatment, is that treatment for flu works a bit like vaccine, because it decreases the viral load of the individual, then it reduces the number of individuals that you're likely to infect. Okay, and anyway, we hope that paper will be out soon and you can read it. Mm. Yeah.
Thank you very much. I've got a lot more questions too, but